Here is the 2016, this is still next step, Chapter 6, Cardiovascular System. Starts with a little bit about evaluation and management services, some information regarding your ICD-10 or your diagnoses of arteriosclerosis or atherosclerosis, how to do your native arteries, or how to code after CABGs, some good information. Starting with case 6-1, this is a cardiothoracic surgery consultation, inpatient. Remember, your location matters. Inpatient. The patient had had a knee replacement or is being considered for a knee replacement and needs a pre-op clearance now. The patient does have 3-vessel disease and has diabetes. So it was determined that they will proceed with the surgery. So you're going to do your inpatient consultation with a 57 for decision for surgery. Your diagnosis codes will be your coronary artery disease and that diabetes. Here's some information about your coronary artery bypass grafts. This is an excellent picture, kind of getting in your mind where the different arteries are that feed, that supply the blood to the heart and keep the heart healthy. The yellow shows different blockages, and then they would bypass around those. This is a really, really good picture. Case 6-2 is a coronary artery bypass graft. How I work these scenarios for the bypass graft, I always look at the procedure performed, because that will kind of tell me how many arteries and how many veins grafts that I'm looking at. And then I go into the actual description of the procedure and verify that I really do have the documentation supplying that. Now remember, in your CPT, if all of the grafts are vein, you pick from that one vein only. If all of the grafts are arteries, you pick from the artery only. Generally, that is not the case. They use the internal mammary artery as a graft, and then they use out of the saphenous vein in the leg for grafts. So usually you have the combination of arteries and veins. So that's most of the time. So you would have to use out of the artery-only section, pick up however many arteries or grafts, and then in that center section there's some add-on codes. And you would pick up a code for how many vein grafts there are and then put them together. Okay, so here it talks about there's 4 different grafts, and it tells you that the left internal mammary went to the left anterior descending, and then sequential saphenous vein bypasses from the aorta to the first and second obtuse, and ongoing to the posterior descending. So from what I can tell here, we have 1 artery and 3 veins. But we're going to read through this and see if this is really true. Also, remember, if they harvest the saphenous vein out of the leg through an endoscopic procedure, then you can use that 33508 add-on code. It would not be first, it's an add-on code, but you can use it. And right here it says the greater saphenous vein was harvested using the endoscopic vein harvesting technique. So that's your 33508. Then as we continue down, I'm a little bit past halfway, and it says the end of the greater saphenous vein was then anastomosed. Anastomosed means one end to another end. Anastomosed to the proximal third of the posterior descending coronary artery. So that's a vein. I put a V there for vein. The graft was brought to the patient's left, and then anastomosed side to side to the second obtuse marginal branch. That's another vein. Followed by the first obtuse marginal branch, which is another vein. So there are your 3 veins. Then it says the left internal mammary artery was then brought down to the mid portion of the left anterior, descending in anastomose. So there's your artery. So I do have evidence of one artery and 3 veins. So your one artery will be sequenced first, then your add-on of the 3 veins, and your add-on to the harvesting. The reason for this was coronary artery disease or atherosclerotic heart disease. When you sequence that, then you go to arteriosclerosis. It's the same thing as coronary artery disease. You'll find that out. Okay, moving into pacemakers. Kind of some good information there, concise, reviewing you. Here is a follow-up note for cardiology. Patient has sick sinus syndrome, dementia, and dilated cardiomyopathy. They've done an echo. They had to review a previous chart. I think I disagree with this level. I think your book has given this a level 5, and I think it's a level, well, we'll leave it a level 5. That's okay. We have a whole lot of history, and I think we have significant enough medical decision making. We just don't have a heck of a lot of examination, but it's an established patient. That's okay. I'd keep it at a level 5. Because we have so much detail in what's been going on with the patient. We also have previous notes. We have an echo, an EKG that has to be, or ECG, that has to be reviewed. We have an echo that has to be reviewed. So there's a whole lot of data. This doctor probably is spending quite a bit of time with the patient. And then combined with the patient's dementia, it's probably very difficult to ascertain correct information from this patient. So it would be a level 5. I gave you the answer, but that's what it is. So your diagnosis codes are going to be that sick sinus syndrome. The echo had showed aortic and mitral valve insufficiency, So you can find a combo code for aortic and mitral valve insufficiency. And then the patient has the cardiomyopathy. I would not do anything with the previous history of congestive heart failure because it does not appear today that they're in congestive heart failure, although that's kind of an ongoing problem. I generally only code the CHF when I know it's being medically managed, maybe by a drug or medication, or it's made mention today that they have it or are in it. And then the patient has that dementia. Okay, moving into echoes. Remember, you can have a transesophageal or a transthoracic. Some good information here about the valves and valve insufficiency. 6.4 is your echo. What I do is I pull out the information that I'm going to need in order to find the right code. That's the M motion, the 2D color flow Doppler, or just plain Doppler, M mode. That kind of information is what I need to pull out in order to find the correct code. You also need to know if it's transthoracic, which is just through the chest, very non-invasive, or if it's transesophageal, which is very invasive. So here they've kind of given you the answers, how to look it up. They have moderate tricuspid, they have some pulmonary insufficiency, and then the aortic and the mitral insufficiencies, which can be combined. So I think because all 3 valves, this is new for ICD-10, because all 3 valves are insufficient, I think there's a combo code for all 3. And then you've got your pulmonary insufficiency. Good discussion here too. So now moving into a Holter monitor. This one, from a diagnosing standpoint, is a little odd. So we're going to talk about it a little bit, but this patient is getting a Holter monitor for their atrial fib. Patient is being treated for their atrial fib. Patient also has known cardiomyopathy. The interpretation is atrial fib. There is some non-sustained VTAC that they talk about. So I would code the atrial fib, the cardiomyopathy, and then the VTAC. They do say down here that the patient does have congestive heart failure, and there are medications for it, but I do not believe that the presence of congestive heart failure has any pertinence to this Holter monitor report, and the physician didn't end up picking it up. So in this particular instance, there again, I would not code the CHF, although it's sitting right there. I just don't see that it is pertinent to this note. We have enough other diagnosis codes to get this paid and complete based on the documentation that the doctor's given us. So 5B is a radiology report, pre-implementation or implantation. Sorry, I said that wrong. Pre-implantation. This is a 2-view chest x-ray, 6 sinus syndrome, and the cardiomegaly. That one you should have no problem with. Here is the pacemaker implantation. This is for bradyarrhythmia, slow heart rate. So they put in a dual chamber. They talk about the leads, multiple being put in. So you should have no problem putting this in. Then they're going to have a post-implantation. Implantation. I don't know. I'm mixing up implementation and implantation today. Again, for bradycardia, this is just a follow-up chest x-ray, making sure that the placement is adequate. Okay, moving into stress tests. We've talked about these quite a bit, I think. This stress test on 6.6 is the supervising and interpreting of the stress test. So the stress test would have been done someplace else at the local hospital. It says that. So you need to code accordingly. Remember, we're only coding for the physician perspective. So you have his supervision and his interpretation. They end up coming up with a CAD, coronary artery disease, and the patient had had a prior myocardial infarction or a prior heart attack. 6B, this is a perfusion scan. Should be pretty easy. For CAD. Here's another echo. Again, I do read an echo report because you never know when you're going to have those valve insufficiencies and stuff. But the first thing I do is I go in and I find, and you can actually find it right here, M mode, 2D echo, Doppler, and color flow. So those are the information that you're going to need to pull out in order to find the right code. Remember your 26 modifier because we're coding from a physician standpoint, professional side. This patient had chest pain, and they ended up with a little bit of hypertrophy over here, or mild. Okay, so they're telling you that they have mild aortic insufficiency with mitral, so you'll find that combo code, and that the hypertrophy that they're talking about is just a side effect of those insufficiencies. Okay, 6.7, cardiology consultation outpatient. Patient is having some chest tightness, so this is just an outpatient consultation with some intermittent chest tightness. So your ICD-10 code will be a little bit different. It'll be a variation on that chest pain code. It'll be just a touch different number-wise. 6.7B, this is a hospital service. You really do, these kind of flow together, and it gets a little convoluted. This one's going to be very confusing to you guys, and I think it's just because the editor or the writer of the book, author, wants you to kind of see how you really have to pay attention to documentation in order to get a code paid. So, and you can't be pulling from all other kinds of data sources in order to get something paid. So the 7B is technically the history and physical going into the hospital. And if you look, the physical exam does not have enough information on it to really even give it a code, which is too bad. But this is just the physician made reference to a previous note. You can't do that. We are only going to code the information that is in front of us. So just as an example for you, going through and counting up your histories and counting up your physical exams and your MDM. This is just an example of how you might see something that doesn't have enough information to even give it a code. Now, in the real world, you would obviously go back and see if the doc would provide a physical exam addendum. Insurance companies do not like addendums because they kind of see that as being done after the fact. They're kind of not happy with that, so keep that in mind, but it happens. The diagnosis codes here will be that ischemic heart, there's a murmur, and then there's the combo aortic and mitral valve insufficiencies. 7C, just a chest x-ray. You see lots of chest x-rays with cardiovascular stuff. So we had some chest pain, and then we had that CAD. I would not consider chest pain a symptom of CAD. If you have stable coronary artery disease, you shouldn't be having chest pain. It's not an inherent symptom of it. Chest pain is an inherent symptom of unstable angina, MIs, that kind of thing. So I would go on and code both of these. There was a positive cardiac stress test which indicated that CAD, but the patient is having chest pain too. So I would code both of them. 7D is your surgical consultation, same patient. This doctor has been asked, this is inpatient, has been asked to render an opinion regarding the CAD. There's the moderate mitral insufficiency. So determine your level. I just gave you the diagnosis codes. They're talking down here about the possible surgery. So that's what this whole consultation note's about. 7E, radiology report, again for a chest x-ray. This patient has rales and is coughing. Rales could be an indication of pneumonia. That's something that a nurse would hear or a doctor would hear when they listen to the lungs. Kind of sounds like your hair being rolled between your fingers right in your ear, kind of like what rales sounds like. So that would be your diagnosis code here. It did end up being a stable chest, so they didn't find anything. So then we're stuck back with why we got the x-ray to begin with, which is the rales and the cough. 6-8 is an echo. Again, look for your M mode, 2D, Doppler, color, whatever that is. You've got your combination of aortic and mitral valve insufficiencies. And then you also have this left ventricular hypertrophy, that enlargement. 6-9, again, a cardiology consultation in patient. This patient had a prior MI. They've got AFib, atrial fibrillation. Here in the physical exam, you find a systolic murmur. Your prior MI, your atrial fib, and then they talk about the patient's anemic from her post-surgical status. So she had lost a lot of blood because of that surgery. She also has some cellulitis at an IV site in her right forearm. So from a CPT standpoint, this one isn't too bad. It's just an inpatient consultation. From a diagnosing standpoint, it's a little bit of a nightmare. So how you sequence these. You have to remember, we have to justify for this being paid this moment in time. So it's a consultation because of that atrial fibrillation. So that will be your first diagnosis. Then you've got the complication of an intra-op hemorrhage. You have your anemia, acute blood loss because of that hemorrhage. You've got your old MI. You have this murmur up here. You have the cellulitis here in that right forearm. And then that previous surgery they had was a CABG. So you've got a bypass status or a CABG. That's a Z code, and we hate Z codes. But it's what it is. 95.1 is what it is. Okay, moving into cardiac caths and stenting. This will be better. This is an actual picture of some stents. Not sure if this is a drug-eluting or not. This is really, really blown up. The stents are just, I mean, tiny, 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 tiny. You can see how the stent is put into a vessel. Here is all the plaque. The stent's put in the middle of the plaque, so the blood is ensured to run through that stent. So, that's a good picture. Okay, 610 is your emergency record. This patient has a history of hypertension, and it's determined that he's having a acute myocardial ischemic event. They didn't call it an infarction yet, but it's close. So this would be an ischemic heart event. Here's your chest x-ray. I'm not going to go through that. You guys should know that. This patient is being put into the hospital, 10C. Now we know it's an acute inferior wall MI and unstable angina. I would not code unstable angina because we know this patient has a heart attack. He's in a heart attack right now. So obviously chest pain or unstable angina would be a symptom of that. So your most definitive diagnosis out of the two would be that inferior wall MI. So make sure that you're finding the specific kind of MI here. Patient does have that hypertension that I would certainly code. And then they're going to take him to a cardiac cath and see what intervention he's going to need. Now, your answers are going to have a 25 modifier on this. And let me kind of explain that because we're kind of going backwards here. In the real world, this date of service would get paid after it had already been completed, the whole day. So you would have all the sequence of events for that day sitting in front of you. The admit or the ER report, the cardiac cath, the stenting, all of that would be in front of you. So you could kind of chronologically put it together. So there is a 25 modifier on this E&M service here, the admit, simply because we had actual procedures that day as well. So we want to get the admit into the hospital paid. We put a 25 modifier on it, which flags the insurance that, yes, we know you have a lot of codes coming in today. This admit was separate and identifiable from the other procedure codes. So that's why it's on there now. It's just kind of a weird timing because this is, it's not in a flow that you would have in real life. So I just kind of wanted to explain that. Okay, here's your cardiac cath, 10D. Now remember, your cardiac caths, they're pretty easy these days. Used to take 5 or 6 codes back in the old days, 5-6 years ago, which I call the old days because things change so fast with coding. Now you can pretty much find one CPT code that includes all of this. So remember, you want to know if it's a left heart or a right heart. This happens to be a left heart. You want to know if there was a coronary angiography done and the left ventriculography. In order for the left heart cath to be complete, that's what all of it's going to entail. So here under procedures performed, left heart cath, coronary arteriography, which is the same as an angiogram, and left ventriculography. And then I just kind of peruse. I see my angiography here. I see my ventriculography here. And then the doctor says there's notable CAD or atherosclerotic heart disease. And then the conclusion, there's a 3-vessel. They're going to decide to do, and then they talk about the MI, the actual culprit of the MI, where that was. So you're going to have your MI for a diagnosis, and you're going to have the CAD for a diagnosis. And then just the one CPT code with your 26 modifier. Remember, we have a technical component with this as well, because in the Cath lab, there were nurses and techs in there. There's a radiological component to it, so there's some interpreting that could be going on. So you would have a 26 modifier. 10E is the stenting that they have recommended. There's actually 3 different CPT codes that you're going to use here. Remember to use your Hicks-Picks modifiers down here for this specific coronary vessel, so that we can track. If you just put a code down without specifying the vessel, it may not get paid. And we have multiple vessels that were worked on. So let's kind of read this. So under procedures performed, they're telling me that they have put a stent into the left circumflex, stent into the LAD, and they angioplasty the RCA. So they did 2 things on the left side, 1 thing on the right. Okay? So then I just want to kind of prove that to me that they did that. So under B, the left coronary system showed 75% blockage, which has now been reduced to 9%. So this would be the stent to the LD. The former 100% stump occluded circumflex, so that's LC, we're still on the left side, L left, C circumflex, has been reduced to 0. And that was the culprit of the MI. There was 100% occlusion there. The remainder looked okay. There was another mid-portion 50% lesion, but they just left it alone. Now they move to the right coronary artery system. And they say there was 95% angioplasty, now successfully down to 20 to 30%. So this is your right coronary. Okay? See, that's not too bad. And then from a diagnosing standpoint, I think the book put your CAD first and then your MI. I would put your MI first. I mean, the whole reason that you got here today was because of the MI. So I would do the MI first, but it probably wouldn't matter. Okay, 611, this is a hospital admission. Pretty straightforward from what we've been doing thus far. Just count up. Remember how I always start with my physical exam first. The reason for the admission is going to be for palpitations, but it doesn't look like they're doing too much, so be careful in your medical decision making. They're going to do an echo and do a Holter monitor. So this doesn't look too significant to me. Now, this B and C, both of these, you don't have to look up any of these codes or anything like this. From a service code standpoint, there's no service code ordering these 2 things. What they're trying to demonstrate here in the book is that there has to be a diagnosis code to establish that medical necessity for these lab reports. So here's a general chemistry report that was ordered because of palpitations, so I would just write palpitations. There's no service code. And then 11C, the hematology, same scenario. From a diagnosing standpoint, you've got the palpitations, and that's why it was ordered, why the doctor ordered it. Here's your ECG here. Palpitations was the indication as to why to have the ECG. They did have a little bit of sinus tachycardia. Since it's just borderline, the rate's 104, I would not worry too much about coding for that. I just don't think it's significant enough. Everything else was normal, so I would just keep it as the palpitations, since the physician who interpreted this didn't seem to indicate that it was too much of a problem. 611C. This is a chest x-ray to view. This patient again has the palpitations, and it is noticeable that there's evidence of COPD in the lungs, so I would probably go on and write that as well, or code that as well. 612, hospital admission for chest pain. This is pretty straightforward. They're being admitted for a stress test. They've had some burning pain. Ends up that their coronary arteries were normal, and now they're going to look at GI reasons for their chest pain. Cardiology consultation. This is outpatient. The patient's already been discharged. Now this is outpatient for the chest pain. They do determine that obviously he has chest pain. They talk about suggestive of GERD. You cannot code GERD because it says suggestive of. That is not a definitive diagnosis. He does have a slight murmur, and he does have mild aortic insufficiency. So those would be my diagnosis codes. Another chest x-ray here. No evidence of any problems, so you're kind of stuck with the chest pain. 12D is your cardiac catheterization report. Again, you want to know left or right heart. You want to know if an angiography was done and if a ventriculography was done. So check out, this is for unstable angina. There's your angiography, your ventriculography. Everything appeared normal. So you default to the clinical indication as to why they had this, which is unstable angina. Here's your GI report. This is an x-ray done right after this cardiac cath. It's an upper GI for chest pain. The symptoms are chest pain, but they determine he has mild to moderate gastroesophageal reflux, and that's probably the source of all of his problems. Okay, 13A, cardioversion. Patient has atrial fib and atrial flutter. 614, this is a transesophageal echo, not a transthoracic. So you can tell down here they're having to pre-medicate the patient with Versed and fentanyl. That would never, ever be done if they were just doing an ultrasound on top of the chest. So this is all transesophageal. Because it's transesophageal, you're going to need 3 different echo codes because you can't find them all combined into one. So you're going to have your transesophageal echo, your Doppler, and then your color flow Doppler. And this is all for mitral valve insufficiency or mitral insufficiency. Here's an op report, a carotid endarterectomy. I was going to look up something on this one now that because let me look this up real fast. You got to bear with me for just a second, because I had a question on this one and I should have already looked it up. So 3. All right. So this is a carotid thromboendarterectomy. Would be common to see an EEG monitoring that's inherent to this procedure. The doctors always check brain waves because they have to interrupt the flow of blood going up to the brain, so they want to always make sure that the brain's getting enough flow. They even kind of talk about there was a few second delay, but it seemed to be okay. So this is of the right coronary artery, so you have mirror images, so make sure you're tracking right or left. And the diagnosis is right carotid stenosis. 16A, this is a venogram of the left upper extremity. The patient has chronic renal failure, so they are doing a venogram to see if the blood vessels in that left upper extremity will support having an AV fistula. Here is your chronic renal failure, CRF. You can see it's CKD too. 16B is that arteriovenous fistula being put in. Remember that when the AV fistulas are being put in, they take a vein and an artery and they anastomose them through a little fistula, man-made fistula, so that when the patient has to have dialysis, they're able to get the blood out faster and then put it back in faster. So here you'll actually see how the vein and the artery are being anastomosed. This is on the left side, so make sure you're tracking left. 17A, same kind of thing, arteriovenous fistula. This is for end-stage renal, so it's a little bit more specific diagnosis code. 48-year-old man, end-stage renal, is on hemodialysis. And then in the procedure, they do a pretty good job of it might be a good read for you. Sorry about my dog barking, I don't know. This is under the procedure. It's pretty good how they describe the vein and the artery anastomosis. It's pretty clear here, which may help you in some of the lingo to get a little bit more familiar with. 18A, this is op report of a AAA, abdominal aortic aneurysm. This one is a very involved note. When I was reading through it, it was crazy. 36-year-old has a ruptured abdominal aortic aneurysm. Didn't know he obviously had the aneurysm until it ruptured. But this patient has a terrible time with hemorrhage. So as the operation description flows, you'll see that there's a ruptured AAA. They talk about opening up the aneurysm. It was completely blown out, which means it blew open just like a balloon. Then they start talking about the distal arteries also had aneurysms in it. They had to over-sew stuff. They sewed stuff out of proximal. They sewed stuff out of distal. The bleeding from the iliac arteries was controlled. They had to go down into the femoral arteries, left and right. And then they opened up the aorta. Thought they were done. They opened up the aorta, and then it said when this occurred, there was extreme backflow of blood into the abdomen through the iliac arteries. So then they had to act on that. We did not sew the opening closed. After multiple attempts to try to control this, we were unable to do so, and again, a large amount of blood was lost. Blood loss was obtained because of this bleeding. They ended up packing the artery off. They anastomosed, but there was, and then down here they say because of the huge amount of blood loss sustained during the operation. So, to no fault of the doctors, this particular patient just had a whole lot of aneurysms. His aorta, the whole bottom half of his aorta was just riddled with defects and aneurysms. And that was very difficult for the doctor. I mean, he's probably lucky that he's not dead. So from a diagnosing standpoint, there's just one CPT, but from a diagnosing standpoint, we have the ruptured aorta, which is why we showed up or had to have the surgery. Then we have all this huge complication of the hemorrhaging during an intraoperative procedure. And then we have the acute blood loss. Very interesting read to me. A pathology report, pretty straightforward for this case 18A. Then 19A is a femoral artery laceration. This one is another just crazy, pretty young person having some bleeding issues. So this particular patient was 57. She went in to have a heart cath, and I guess they nicked part of the femoral artery, didn't realize it at the time, and she bled out. So now they're going in to repair that laceration. So this is a little bit of a diagnosing nightmare, in my opinion. From a CPT standpoint, we did have to have an assistant surgeon on this case. So the code that you come up with to repair this femoral artery laceration, for the first surgeon, he goes on and on and on and on. So I would put a 22 modifier for prolonged services. And I want to tell you that so that when you read it, you see that there's just really a whole lot above and beyond going on here. And then because we have a second assistant, I do not know the extent of the assistant surgeon, but I would use the same CPT code and then put an 81 modifier on it. Just a minimal assist. Now, from a diagnosing standpoint, we have an intraoperative puncture. That's the whole reason we're here. That right femoral artery got nicked, punctured somehow. I think it's the right. Oh, I may just made that up. Yeah, I think so. I don't know that matters. Then we have the patient cardiac arrested while she was in surgery. We also have an intraoperative hemorrhage. And then the patient goes into DIC, which is, if you watch Grey's Anatomy, it's what Meredith went in when she had that last baby. You're not clotting. Your blood's not clotting. So you can just bleed out from every orifice on you. So that would be the DIC. And then he ends up saying that the patient's gone to surgical ICU in critical and unstable condition. So this patient's not in a good place. But from a diagnosing standpoint, you've got 4 different diagnosis codes. So hopefully I've given you enough hint that you can then pick out the information. I will say down here it says, I thought this was most likely coming from the right femoral stick. And then it talks about the husband agreed to a right femoral artery exploration. And then in the actual procedure, we could see that there was a laceration in the anterior wall of the common femoral artery. However, we did not really have the artery very cleaned out at this point, nor could I get proximal control. I think this patient was large because it talks about because of the body habitus. That generally is a nice way of saying that there's a whole lot of extra body there. So it makes their job a whole lot harder. So anytime I see the body habitus and then I have this much of them trying to control bleeding and get to an area where they can visualize what's going wrong, that constitutes your 2022 modifier. All right, and that is it. Thank goodness. And then we're into our auditing. And then digestive will be next.